Dr. Nilesh Lokeshwar, medical oncologist from Mumbai. His panelists are Dr. Hemant Malhotra, medical oncologist from Jaipur, Dr. Bharath Rangarajan, medical oncologist from Coimbatore, Dr. Nikhil Ghadiyalpatil, medical oncologist from Hyderabad, Dr. Amish Vora, medical oncologist from New Delhi, Dr. Mangesh Kamath, medical oncologist from Bangalore, Dr. M.V. Chandrakanth, medical oncologist from Kolkata, Dr. Mostafa Aziz Sumon, radiation oncologist from Bangladesh, and Dr. Arun Shahi, medical oncologist from Nepal. Over to you, Nilesh, sir.
Hello.
Yes, sir.
Please go ahead.
Yeah. Are you able to see the slides?
Yes,
Just
sir.
to confirm?
Yes,
So
sir.
good evening and thank you, Dr. Amish, Dr. Sudeep, Dr. Parekh and Kavina Creations for this evening's meeting and this opportunity. And what we are going to do in this panel is discuss some of these important practice changing papers, the ability to choose wisely, hopefully after discussing all of them. So our focus is on TMBC and these are the different papers that we will be discussing. I invite all my panelists, all our esteemed faculty from India and Bangladesh. So let's just go on directly to the case. Now, this is a 48-year-old lady who is postmenopausal, a significant family history of ovarian cancer in the mother and the first cousin. There's no significant comorbidities, and she presented with a right breast lump since 2 months. There were no other symptoms. Clinically, there appeared to be a localized disease. These were her further investigations, a mammogram that had a BI-RADS of 5, a PET scan which showed a right breast primary with a right axillary node. She underwent a true cut biopsy from the right breast lump, which showed an infiltrating duct carcinoma grade 3, which is ER negative, PR negative, and HER2 negative. So we had a diagnosis of CA right breast, clinical stage T2, N1, and N0. So my question to the panelists is, what are the treatment options in this patient? And the first two enlisted options, that is surgery followed by adjuvant chemotherapy followed by radiation, versus a preoperative or neoadjuvant therapy followed by surgery, BCT, and adjuvant radiotherapy. So can I request Dr. Hemant Malhotra to answer this?
So hi Nilesh, can you hear me?
Yes, sir. Yes, sir. Yes, sir. You are.
So I think in this patient who has a locally advanced disease, my choice, and she has a triple negative disease, we know that these patients are quite chemoresponsive. My choice would be to give the patient neoadjuvant chemotherapy and make the job easier for my surgeon to do a breast conserving surgery. And then once the is done, then she will of course require therapy. So neoadjuvant chemo in this patient.
So anybody in the group has a different opinion? Anybody would advocate upfront surgery in this patient? Dr. Bharath?
I may not, thank you Nilesh, I may not advocate upfront surgery in this patient. But if the patient is extremely keen for a breast conservation surgery, then I think that further evaluation is definitely required to see if a breast conservation can be done post NACT and how safely it can be done. And that assessment is basically by the surgeon. And this patient may even require a MR mammography and placement of a fiducial or a sort of a clip to make sure that where the epicenter of the tumor is, if you're going to give neoadjuvant chemotherapy, it's a little bit more expensive, more tedious if you're going to plan BCS after breast conservation after neoadjuvant for this lady.
Okay, Nilesh, can I add something?
Yes, sir.
I think right at the beginning, this patient should be seen in a multidisciplinary setting, and the surgeon needs to be involved from day one, even if you're planning neoadjuvant chemotherapy, because we know that about 40 or maybe 50% of these patients can have a PAT-CR in the breast, and then the surgeon is all at sea as to what part of the breast to excise. So they might be tattooing or clips or whatever is the surgeon's favorite. So that I think is an important message for the younger medical oncologists, that from day one this patient should be evaluated in a multidisciplinary way.
And if I can add something,
Dr. Nilesh,
if I can add something, Nilesh, I would also like, if I'm starting neoadjuvant, to get a BRCA1, BRCA2 for this patient upfront, so that we have that information by the time she's going to the surgery.
Okay,
So
somebody
one
was.
more thing I want to add, Nilesh, Dr. Mangesh here. So I just
Yeah.
wanted to add is if there is I was just going to continue from Dr. Bharath is that if you do have BRCA1 or 2 mutation, there is still a small higher risk of recurrence after a BCT that should be discussed with the patient. Maybe the survival is not changed much, but recurrence rate may be a little higher in these patients. So I would discuss that with the patient before offering them a breast conservation therapy.
Thank you, Dr. Mangesh. Amish, can I get you in? A common
Yes.
problem that most of my surgical oncology colleagues say, and this is particularly because many of these patients go to them first, is that we'd rather prefer to do upfront surgery. What are your views and what are your experiences on this?
I think triple negative breast cancer in 2020, upfront surgery, anything above T2, especially in this patient when the node was positive, is not the scientific way to treat this patient. Knowing fully well that we are looking at pathological CR in these patients. But having said that, if, again, if we can have Dr. Sudeep on this, the pathological CR also is the way of nature selection for good patients, and they will do well even after adjuvant treatment. So we have
I think we'll come to that point of
Yeah.
CR a little down the line. This is just
Okay.
a plan because this is a practical point raised by most surgeons. And I also agree that NACT is a way to go. What about the indications for NACT? Is it all of the above or one of the above or some of these above? Can I ask Dr. Nikhil to come in?
Am I audible here?
Yeah, you are.
Okay. So I think Dr. Hemant and Dr. Bharath have already enlisted the reasons why this particular patient is for NACT over here. And one of the reasons is, of course, the nodal positivity, larger primary for this patient. So locally advanced breast cancer itself becomes one indication over here. Second indication, what I think has already been discussed extensively, was the BRCA, because there might be some time to get that report in place. So it did a good way to look at these patients from the NACT point of view, because if you want to do a bilateral surgeries for some patient, bilateral mastectomies, then that also comes into the picture or comes into the thoughts and discussion. And thirdly, what Dr. Amish has just now mentioned is the pathological CR. I think in the current scenario, whenever a patient like this comes to me, I would like to start tailoring the treatment from the day one, how I'm going to approach this patient from the day one, from the entire treatment point of view, and how we can maximize the use of various treatment options, whatever we have, and with the understanding that this patient's in vitro response, in vivo response also can be monitored in this patient, and that also gives some kind of information.
So you'll be able to select a biological worse group of patients whom you can consider some escalation.
Possibly, right? Yes.
Dr. Chandrakanth,
yes, sir.
Any additional tests that you'd like to do for this patient?
So of course,
I would 4 tests.
Yeah, I think even Ki67 and HRD, as you mentioned, that's also a way of selecting patients.
So is an androgen receptor test really relevant?
We don't do it as far as in the new adjuvant setting. So I just wanted to add one more point. As pathological complete response, should it be considered at all an endpoint?
I think we'll come to that a little down the line. Let's come to the endpoint later.
No. So whether to give NACT for whether it is LABC or whether it is localized. So now the tendency is that not only a node positive disease, even if it is operable in triple negative breast cancer, I would like to give neoadjuvant chemotherapy. If you look into the HER2 positive subgroup also, where Catherine says that by escalating the adjuvant therapy, we can add to overall survival. So we can add to overall survival in the adjuvant setting, provided the adjuvant drugs really overcome the resistance of the neoadjuvant drugs. So if we talk of Createx,
I think that's something that will be discussed a little down the line.
So in triple negative breast cancer, so neoadjuvant chemotherapy as a biological selection is not that great because the adjuvant chemotherapy is not that effective like the way we have in HER2 positive breast cancer, where the resistance is actually overcome. And that's
maybe I'll be able to change your mind down the line. So, pathological CR, among these three definitions, what do you consider? Dr. Sumon, are you there? Dr. Sumon, Dr. Mostafa, Aziz, Sumon? Okay, Dr. Arun Shahi?
Yes. Yes, sir.
Dr. Shahi, there are three definitions in front of you. One is a path CR in the breast. The second is a total path CR where you have an absence of invasive cancer in the breast and axillary nodes irrespective of DCIS. And the third is the German group definition where they also want the absence of DCIS. Which among these is the correct one that is used currently?
I think the first one is the second one, sir. The second
correct.
one.
So the absence of invasive cancer in the breast and axillary nodes, and that is irrespective of DCIS. I think that's an important point to note. Like mentioned by my earlier panelists, there is a strong association between path CR and those patients have a better EFS and an OS. But is this entirely so, and can this be extrapolated to clinical trials? Now, this is the CT-NEO-BC analysis published in 2014, which clearly said that patients who have HER2 positive disease as well as TNBCs tend to have a higher pathological response. And these again are those patients who have a better overall survival when they have a pathological response. But when it came to the final analysis, one thing was very clear, that while the individual patients had a significant improvement in OS and DFS, at the trial level analysis, there was no association between the increase in the frequency of path response and the treatment effects on EFS or OS. So this is a relatively older meta-analysis that came out in 2014. And since then, there have been many other meta-analyses. Let me take the opinion of our panelists. Dr. Malhotra, what is your opinion regarding the relevance of path CR, and is it a surrogate marker for survival?
So I think it's an extremely important indicator of your subsequent disease-free survival and possibly your overall survival. And I think it's an endpoint or a goal which we should strive for and get to and achieve if possible. So I'm all for PAT-CR. If my patient has PAT-CR, then I'm very, very happy.
So this second meta-analysis that was published sometime in March this year has clearly shown that those who have a PAT-CR have a significantly better OS than HR of 0.22. And this was in a large meta-analysis of almost 23,000 patients. And what the conclusions were that achieving a PAT-CR after NACT is associated with a significantly better EFS and OS, particularly for TNBC and HER2 breast cancer. However, adjuvant chemotherapy following PAT-CR after NACT did not improve outcomes in this particular study. And they have accepted that in this, their conclusion is that PAT-CR is a surrogate marker endpoint for TNBC and HER2 positive breast cancer. And it supports the FDA's decision to use this as a surrogate endpoints. Amish, any comments on this?
I completely agree with what you have presented, Nilesh.
You do. But maybe that is not the entire truth. So in June this year, we had the third meta-analysis on the same subject, evaluating survival outcomes in neoadjuvant versus adjuvant therapy in TNBC. Now, this was specifically for TNBC. The earlier meta-analysis had a mixed group of population, including ER/PR as well as HER2. Now, look at graph A, or the forest plot of A. Here, the hazard ratio for overall survival, NACT versus adjuvant chemotherapy, was in favor of adjuvant chemotherapy. So, for the whole population as a group, NACT did not improve survival. Come to B. Here, in patients who received NACT, who had a pathological CR versus adjuvant chemotherapy, these patients did significantly better. Similarly, patients who had an NACT with a residual disease versus adjuvant chemotherapy, patients with a residual disease, as expected, did not do well. So here there seems to be a bit of a dichotomy as we are seeing it. The overall group shows that adjuvant CT is better than NACT.
Nilesh.
Yeah.
So this meta-analysis has not taken Create X and the Korean study, which is
it hasn't. No.
And that's precisely the reason why, one of the reason apart from PAT-CR, that we like to give NSCT because we have a drug to give.
So there is another analysis of this, and I request Dr. Bharath to come in. Any opinion on this?
The differences in these meta-analysis have basically been because of the inclusion of some trials and exclusion of some trials.
Correct.
So that is something that we cannot get away. And when you're looking at these large data, you cannot really, say that we'll change our practice or we'll, do something based on just these meta-analysis. We also have to look at these individual trials. And when we look at the trials in, say, triple negative, in HER2 positive, all these patients, we know that now the PathCR rates are anywhere between 40 to the high 60%. We know that these patients who are achieving PathCR are doing better. And we also know that if you don't achieve a PathCR, you're going to escalate their treatment. So we have to factor in these issues and decide. So I think PathCR, whether we see them and, we stop treatment there, or we escalate in the adjuvant setting after that is very important. So these meta-analysis do give us a, sort of guideline, but in practice, I think we have to look at these aspects also. It's to stratify further treatment. We can't forget that.
Nilesh, Nilesh, I just want to, I am Dr. Mostafa.
Oh, hi, I didn't know you were there. I
Yes,
I
was a bit interrupted by sorry for that. So I just want to repeat Dr. Amish statement. Because this study did not take in consideration the CREATE-X and the Korean trial. So that's why for triple negative breast cancer, we should prefer neoadjuvant chemotherapy rather than adjuvant.
Point noted. So I think essentially in many of these studies, the neoadjuvant chemotherapy was typically reserved for those with larger tumors. And that is one big explanation. The second thing also was that in the patients receiving NACT, there was probably a higher local recurrence, and that is probably the reason why there is no difference in the DFS, but there is an OS difference in these studies. So I think at the moment, the panelists do agree that pathological CR may be considered as a surrogate for OS. Anybody who disagrees with this, and I'm speaking specifically about triple negative breast cancer, not HER2, not ER positive.
Nilesh, I have a point here to make. Pathological CR based on the standard chemotherapy what we have been giving so far has been proven beyond doubt as a surrogate, is a OS marker. But with the newer drug entering into the era, and I'm sure you would discuss how much improvement in PathCR would actually improve OS in future, is a question which is not answered as yet. So I'll be little careful there.
Fair enough. So I think with conventional AC taxane based therapy, you're looking at a PathCR of somewhere between 35 to 40%. So we agree that in adjuvant therapy and TNBC, sequential anthracycline, cyclophosphamide, taxane based therapy is the standard of care. We have the option of dose dense in high risk patients. We have alternative regimens in patients without anthracyclines and those without taxanes. And one thing is clear, that neoadjuvant therapy is equal to adjuvant regimen, and probably preferable in this subgroup of patients. Let's come to the newer development that has occurred in the last 2 or 3 years. What are your thoughts about the addition of these different drugs? That is the platinums, the PARP inhibitors, and the checkpoint inhibitors. Dr. Malhotra?
So I think, can you repeat your question, Nilesh, please?
So I'd like to, like I mentioned, that with NACT, using an AC and paclitaxel or taxane, you get a PathCR of somewhere around 35 to 40%.
40%. Yeah.
What about how do you increase the PathCR? How you improve the delta in this situation? What are the different options that we can consider?
So I think like one, so to say, more popular or more conventional option is adding a platinum agent. And the second thing in the past 1 year is the addition of checkpoint inhibitors to the neoadjuvant regime. And there are 2-3 studies which do show that you can have an increment in your PathCR by between 10 to 15% if you do these 2 strategies.
So what we have understood over the last few years that is TNB itself is not a singular disease, but it's a very heterogeneous disease. You have the basal type, the non-basal type, the AR type. Is there any particular subgroup of patients where you would think that platinum would make a bigger difference when added in neoadjuvant setting? Nikhil, can I request you to come in on this?
Who's that directed to me?
Nikhil?
Sorry.
Dr. Nikhil?
Yeah, I'm here. So there has been a suggestion that BRCA positive patients are probably more sensitive to the platinum-based therapy, but that is just a suggestion, because as we really go and dig deeper into most of the trials, even in the patients who are BRCA wild type also, there has been a decent responses even with the platinums. So platinum is one option which has been discussed extensively in multiple trials, with bevacizumab, without bevacizumab also. And there has been improvement, I would say, by delta. I would say if I really compare with without platinum-based therapy trials, we can probably go up by another 10 to 12% in terms of pathological CR rates. Having said that, we have got a lot of data for right now for DFS or EFS, but there is no very strong data for OS as of now, as far as platinums are concerned.
Dr. Mangesh, what is your opinion about adding the PARP inhibitors in patients who have BRCA mutations?
Yeah, so my thought process is right now for neoadjuvant, we do not have much data to speak of, but there is the Olympia trial that we will have the results of that. That may tell us if there is any role in the non-metastatic setting for PARP inhibitors. But I will certainly speak of now an established role for immunotherapy, which possibly can be used, and that again there is some data that is coming up for immunotherapy in the neoadjuvant setting.
In patients who have a triple-negative breast cancer, how many of us among the panel are routinely using cisplatin along with taxane? So AC with Pacli versus AC with paclitaxel with carboplatin, or are you doing this in a particular subgroup of patients? Dr. Amish?
Nilesh, patients who do not respond well to the standard chemotherapy, I add platinum right now, because we do not have any category 1 consensus recommendation for adding platinum upfront.
So you mean to say after 4 AC, you evaluate, see the clinical response and decide?
Yes. In fact, sometimes weekly paclitaxel, in case if I start an elderly patient first before AC, and after 4-5 weekly taxane, if the response is not good, I discuss with the patient and add platinum in these patients. If practically speaking, I would love to add platinum from day 1.
Nilesh, can I make a comment here?
Yes.
So not for all patients, for a very select group of patients, I believe there is some suggestion and some consensus about patients who are probably BRCA positive, where there is a bit of benefit of use of platinum, but not for all the patients for sure as of now. And I routinely don't use platinum in the setting as of now.
Nikhil, BRCA positive in a metastatic setting, it has been proven that addition of platinum almost doubles the response. But if you see JEPAR 6-2 trial, the BRCA negative patient benefited better to platinum compared to BRCA positive.
I totally agree with you over here, but at the same time, when you go by the consensus guidelines, I just spoke about the consensus as of now. The NCCN does not recommend as of now platinum, but if you read by the European guidelines, probably they do have some suggestion that probably BRCA. So the patients on NCT who are BRCA, who had got a PCR, are the patients are going to do the best, and these are the patients probably have done best with the platinum, and that's my suggestion.
So Nikhil, you're right about the recommendations, and Amish, you're right about that clinical trial also. So we know that while a platinum augments the PathCR in TNBC, however, it has a very inconsistent improvement on the DFS and the OS. And coming to the GEPAR 6-2 trial, now this is a group of patients where patients are randomized to receive paclitaxel with carboplatin and liposomal doxorubicin versus paclitaxel and liposomal doxorubicin, and this was in the neoadjuvant setting. If you see the response rate was significantly improved over the control arm, almost 36 to 53%, but the DFS for the overall group was not significant. And like Amish mentioned, It is only those patients who had developed a pathological CR, irrespective of whether they were BRCA wild type or mutant, had a significant improvement in the DFS. So there is still some lack of our understanding about these patients because many of these trials have given us contradictory views. So the brightness study is a significant phase 3 trial where they've been used a combination of velaparib with paclicarbo versus paclitaxel, and this gives us a little more idea about using PARP inhibitors versus taxanes versus platinum in this group of triple negative patients, and only 15% of these patients were BRCA positive. So the primary objective in this was PATH CR, and as you can see, both the velaparib plus paclitaxel and carboplatin arm versus the paclitaxel and carboplatin arm had a better PATH response, had a better breast conservation surgery, a better clinical response, and a better or lower score of residual cancer burden at surgery. The arm that did not do well was a single agent paclitaxel arm. So while this does show that the combination of a PARP inhibitor and a platinum works, it also shows that paclitaxel with carboplatin also works. Any comments on this? Amish, you are coming to this study also?
Nilesh, can I make a comment?
Yeah, sure, sir.
So like what I do on the practical front is that if there is a more advanced TNBC, say like a T2 or T3 disease and nodes, then after the 4 cycles of AC, I do paclitaxel carboplatin for them for 4 cycles. Of course, the patient has to be in good general condition, and of course, explaining the patient, even though it's possibly not standard of care and not in the guidelines, but I do 4 ACs and then 4 paclicarbos and then the local treatment.
Okay, so these are several PARP inhibitors, and we'll skip this in the interest of time. So I'll ask a very simple question. If we were given a choice, and this is 2 different phase 2 trials, this is a cross-trial comparison, I've just enumerated them side by side, of talazoparib given for 6 months as neoadjuvant versus cisplatin given for, I think, 4 cycles for 3 months. Look at the difference in the pathological CR. It's 53% versus 61%. And look at the difference in the cost of both these trials. Dr. Sumon, any comments on this?
I am pretty agreed with this decision because I will favor platinum in respect of TNBC. And right now, irrespective of the BRCA status, I am a little bit conservative with PARP inhibitors. I will prefer cisplatin.
So I think single agent PARP inhibitors currently have no role in TNBC in the neoadjuvant setting, and a taxane with a platinum combination is probably what most of us are tending towards. What about the latest kid in the block, neoadjuvant immunotherapy in triple negative breast cancer? Now we have 2 trials that are ongoing, the Keynote 522, where patients with TNBC have received pembrolizumab with chemotherapy, where the choice of chemotherapy has been taxane with anthracycline, followed by surgery and then maintenance pembrolizumab, and the atezolizumab study, which is the GEPARD-2 study, where there is atezolizumab with pacli and carboplatin. Now, even in the Keynote 522 study, the partner drug is paclitaxel and carboplatin. So one thing that definitely tells me is that the answer of whether to add carboplatin in a TNBC in the neoadjuvant setting probably is answered, because several of the current studies are using this as their control arm. Dr. Amish, would you use immunotherapy in a patient who says that money is not a problem, I can afford it?
I have one such patient, and that was also one of the reasons of keeping this panel.
Only you can have one such patient. Okay.
Keeping this panel to answer that question, I would like to answer when you present the results of the study further, what my take is.
Okay, fine. So basically, these were patients who are unselected, and they received, so they were not selected by PDL1 status, and they received paclitaxel carboplatin plus AC, followed by AC. Along with this, they received pembrolizumab, 200 milligrams every 3 weekly, followed by surgery, and then maintenance pembrolizumab for about 9 cycles. And the control arm received AC paclitaxel carboplatin followed by AC, and then surgery. Okay, so this was the primary endpoint was PATH-CR, and as you can see, there was a significant improvement in the PATH-CR. Although to note, the placebo and chemotherapy arm also had a significant improvement in the PATH-CR of 51%, and that is likely because of the use of carboplatin as the chemotherapy backbone in this study. So Amish, you have this data, your answers please.
These tells two interesting things. If we have to believe nature's way of selection of good patients with PATH-CR based on taxane plus AC, here the delta in PATH-CR has increased from say 35% of the conventional chemotherapy to 64.8%, Nilesh.
Correct.
Almost double the PATH-CR of what we are used to seeing without the use of platinum.
Correct.
My take on this is that if medico-legally I'm allowed, I would love to change my practice based on this data. And I'm sure that this will translate into overall survival benefit in future.
You mean to say change your practice to using a platinum or change your practice to using pembrolizumab?
If I use pembro, automatically I have to use this trial, and I would love to use platinum. As I told you, I would like to use platinum. And see, you presented many meta-analysis, Nilesh. There's one meta-analysis from Julie Bordet Institute in Brussels. And they have clearly said that the platinum addition adds on to OS and PFS. And the worst case scenario is that it adds on to hematological toxicity. My question is, what do we lose by adding platinum? Nothing. And here this keynote 522 clearly says that 35% to 51% to 64%. Almost 2/3 patients we are entering into PATH-CR.
Agreed, but that doesn't answer whether we should add pembrolizumab to this. So in my opinion, this is anyways the DFS, the EFS data is still immature, and that is awaited. Dr. Malhotra, would you consider using this combination in your patient with TNBC?
So I don't think I would use a checkpoint inhibitor, either pembro or atizo, in all the patients of TNBC. But if a patient is very, very keen affording the sky and has a large volume disease to start with, say T2, N1 or more than that, then I would certainly discuss that with the patient, that we have this data available today. And if you want to come on board, we could think of this. Of course, I would get everything in writing, but I would certainly explain to the patient that we have possibly preliminary evidence that we can add on to the benefit of our standard treatment. And as I already said, that in my standard practice, I do incorporate a platinum in the neoadjuvant regimen.
Okay, fine. In the interest of
Dr. Nilesh, Dr. Nilesh, I'll put a point across.
Yeah.
So there are, I have a patient in my clinic whom I'm actually having conversations about introducing, because the patient has heard that immunotherapy works well with TNBC. So the 2-3 things that I would like to know is, in this patient, if I have to really push my push forth, is again, as you have pointed out in your slide, that it should be a large tumor with a lot of nodal volume. Second would be, I would definitely want to check the CPS score in these patients. Definitely, if the CPS scores are more than 10, it has been found that it works much better or gives much better PFS.
You're right, but that CPS score that is relevant is for metastatic disease. In fact, this study has clearly shown that irrespective of the PD-L1 score, patients have a higher pathological response. And so my question.
Yes. But when we are trying to put forth immunotherapy, we have that extra ammunition that whenever we do recommend it in a non-metastatic setting, if at all your PDL level expression is a lot better or your CPS is better, it actually gives you a lot more confidence in trying so.
Correct. So I would definitely leave this to the experts to give a final opinion. But in my opinion, with the recent surprises that we've been having, especially with the chemotherapy partner and the concomitant use of steroids, I would be very wary about using this across the board for my patients. Even a patient who pushes me for it, I would rather wait for more mature data to take a call on this. I think in the interest of time, let's go to the next case. So the next discussion. So this patient completed neoadjuvant chemotherapy. I was able to convince them to take 4 AC followed by 4 paclitaxel in a dose-dense fashion. Clinically, the response was good. The lesion was non-palpable and the PET was in CR. She then underwent a right VCT with an axillary node dissection. Unfortunately, in this, there was a residual disease, and there was 1 centimeter residual disease showing IDC cells and 21 nodes that were negative. So there is a residual disease. My question to Arun, Dr. Arun Shahi is, what would you advise this patient in this situation? Dr. Shahi? Dr. Mangesh, can I ask you to take this?
Yeah, so, hello.
Yeah, am I audible?
Am I to respond? Hello?
Dr. Mangesh, yes. Who's
so,
this? Yeah, okay.
Yeah, this is Mangesh here. So yeah, so in this patient, I know there is a residual disease. So my option would definitely be to recommend an adjuvant capecitabine to this patient.
Okay, Dr. Shahi, are you here?
Yeah. Can you hear me now?
Yeah, tell me, Dr. Shahi.
Yeah,
in your practice in Bangladesh, what would you do?
So I am from Nepal.
Oh, sorry. I'm sorry. I was given a wrong information. My apologies.
Yeah. For this patient, like there is a residual disease, I will go with the capecitabine as adjuvant therapy.
Okay. So this was the landmark study that actually made us change our mind about dose escalation in patients who do not have a complete response. And this was, of course, a study that included ER/PR positive both patients as well as those who were TNBC patients are randomized to get 2,500 milligrams of capecitabine per day for initially 6 cycles, and finally the trial had them taking it for 8 cycles. And if you look at the results, the disease-free survival and the OS was significant, especially so in patients who are triple negative, showing a significant improvement of DFS and OS in this group of patients. So is everybody convinced on the panel that this is the way to go for all patients who have a residual disease?
Nilesh, I have a point. Amish here.
I recognize you, Amish. Go ahead.
2,500 milligram per meter square. My first 4 patients, they did not tolerate. They did not tolerate. We did not have the study of ESCO 2020, which next you are going to discuss. Till that time, I could not complete the dose. My question is that 2,500 milligram multiplied by 1.7, 1.8 surface area, people are, after chemotherapy, surgery and radiotherapy, people are not able to tolerate in the practice where I am practicing. So my point is,
especially somebody who's taken paclitaxel, has residual neuropathy, it gets a little difficult.
Yeah, so that is my biggest issue.
Dr. Nikhil, what are your views on this?
I do practice the Createx protocol in my practice, especially for the patients who are not achieving PathCR.
So what percentage of your patients are able to complete the 6 months of therapy? That is about 8 cycles.
I at the same time, I do agree with what Dr. Amish said. Probably I don't go for the dose what probably is recommended. I think the dose probably what most of us are probably comfortable, maybe 3.2 or 3.3 max. Beyond that, we normally don't go.
So we are already using a semi-metronomic dose.
There is a challenge for sure over here, but that's what probably, these are the, I would say, real practical issues. Can't help it.
Okay. So we also had data coming in last year from the GCAM study, which was specifically for TNBC. These were again patients who had residual disease after giving chemotherapy, which include AC as well as taxane. And these patients were randomized to a slightly lower dose. This was 2,000 milligram per day, 1 gram divided into doses, and again for 8 cycles versus observation. Unfortunately, in the intention to treat group, the DFS and the OS was not significant, indicating that the primary objective of this trial was not met. It was a negative trial. But in a pre-planned analysis that they had done, where they divided the patient into the basal and the non-basal type, there was a significant improvement in the DFS as well as in the OS for triple negative patients who are non-basal type and who have residual disease. So Amish and Nikhil, both of what you mentioned that patients can't take the full dose. If you drop the dose, this is what happens. Dr. Hemant, can I ask you to give your opinion on this?
I think I agree with Amish and Nikhil. It's practically impossible to give the full prescribed dose to the patients in the Indian context. And if I were to go on a gut feeling, my take is that if you reduce the dose a little bit, make it tolerable to the patient, then you don't lose very much. So that is my gut feel.
But we have this data which shows that at a lower dose, you probably are not getting that kind of a benefit.
Yeah, so I guess you should start at the full dose, and for the 1/3 to half of the patients who don't tolerate, you reduce the dose, but don't start with the reduced dose, but because you may have half of your patient be able to take the full dose. So start at the full dose and reduce if toxicity is there.
So a point to note was that the CREATEX study was mainly a Japanese and a Korean study. And we know that there are differences in ethnicity with respect to capecitabine-based tolerance. And this present study, the GCAM study, was a Europe-based study. And they have considered this and therefore taken a lower dose. Dr. Chandrakanth, can I have your opinion on this?
Yeah. Nilesh, can
Yeah. So I totally agree with you as far as capecitabine in Japanese population, because even in stomach they have used single agent cap and shown a benefit which we have never seen, 70%. So there is a relation with capecitabine, tegafor-uracil with Japanese subgroup of population. So we cannot use that dose in our Indian setting.
Correct. And the Indian population's tolerance is probably even lesser than this. Nikhil, you were saying something?
Yes. So I do agree that this GCAM study has been a negative study. And at the same time, we also need to look at some differences the way from the CREATEX study. In this GCAM study, all patients, all comers have received capecitabine. So with irrespective of the PCR or not, patients have received. So it's very difficult to compare one study over the other over here. And so probably there are some issues also in this study.
So, and two groups of patients did have a significant improvement in DFS and OS. That was the non-basal type and the patients who had completed or received adequate therapy. Now, this non-basal versus basal is a little important because non-basal actually includes those patients who have BRCA negative tumors, whereas basal includes those patients who have BRCA positive tumors. So there may be an indirect way of looking at this also. So this year I'll just keep this in the interest of time. So this year in June, we had another third trial. Now this is from China, where we have a phase 3 trial of metronomic capecitabine after standard therapy in operable breast cancer. Here the patients who had residual disease received a much lower dose of capecitabine, 650 milligram per meter square given BD continuously for 1 year. And while they had a significant improvement in the DFS, they did not have an improvement in the OS. So is this a choice of treatment, Amish?
Absolutely. Even though they did not have significant OS, there was a difference in the OS. They did not have a significant, but 5-year DFS, if the absolute value you see 83% versus 73%, which is higher than the absolute value of CREATEX. And this is doable in Indian population. Indians would tolerate 650 milligram per meter square easily. I would definitely like to believe in this data.
Dr. Sumon, what are your views?
Yes, I would.
Which dose and what duration?
Yes, I would rather differ with Dr. Amish because in my clinical practice, I experienced that after getting neoadjuvant chemotherapy surgery, patient, it would be very difficult to continue around 1 year. So I would rather prefer CREATEX dose. We initially started with the exact dose, and we had a different experience. Some patient tolerate very well and some patient not. So let's see who tolerates well. If she can tolerate well, I will stick with the CREATEX dose, and if we need, we will reduce it later. So I would rather prefer CREATEX.
Comment?
Yes, Nilesh.
I think, Nilesh, one quick comment. If somebody could update me on this. I think Dr. Banawali has a protocol of metronomic treatment ongoing at Tata.
Correct.
It's a relatively long time, and I would love to know the results if somebody has the results.
Correct. I think that that is a combination of different drugs, not a single agent. But yes, that would be definitely interesting to know the results of that. Bharath, you were saying something?
No, nothing. I think that the dose of 2000 milligram per meter square, the GCAM dose, is fairly well tolerated in our patients. But as you rightly say, whether it's going to benefit everybody across the board and whether it is really stratified to path response, that is the issue there when we're using that dose. but that dose is tolerable.
Note the last row that I have, where you see the number of patients who have completed or the relative dose intensity. In patients who've got the lowest dose, the relative dose intensity is much higher. And I think this is something that we know. What I feel is probably we'll either be using 2000 milligram per meter square or 650, or that is 1300 milligram per meter square, or actually somewhere in the between the two, not in a continuous format, but giving gaps based on toxicity. I think that's a practical way how we'll be managing most of our patients in India. So this patient, unfortunately, at that time, this data wasn't there and did not receive any capecitabine. So follow-up after 6 months showed a liver metastasis. There were multiple SOLs with pulmonary nodules. The patient was asymptomatic. Performance status was good. There was no neuropathy. Biopsy from the liver lesions show metastasis consistent with from a breast primary. The ER, PR, HER2, and AR was negative. And the germline testing was done for this patient this time, which showed the presence of a BRCA1 mutation. We also did a PD-L1 testing, which showed a score of 5%. Dr. Hemant, how would you treat this patient? What are your treatment options?
So the patient has obviously quite significant amount of disease, and even with the disease, she remains in good general condition. I think at this time, PARP inhibitor might be the right way to go before we start her on second or third line chemotherapy. So I would think of a PARP inhibitor in this patient at this particular point of time.
Dr. Bharath, would you prefer immune checkpoint inhibitor?
Actually, this patient, what I would do is I would definitely start her on chemotherapy because she is triple negative and has developed visceral disease. Now I would put her on chemotherapy. I might not start her on PARP inhibitor at this point. I would give her chemotherapy. But having said that, this patient would be a candidate for PARP inhibitor at some point of time, because we know even in the Olympiad, patients who took chemotherapy and then went on, they all had a PARP inhibitor and platinum at some point of time after, even in the experimental arm and the trial arm. So they will do. So I would give chemotherapy here, but at some point of time, PARP inhibitor, yes.
Okay, so we have
Dr. Nilesh, Dr. Nilesh, Mangesh. So if I have to give this treatment with this patient with PARP inhibitor, I would do it right now rather than later. But I may still have the choice of giving immunotherapy at any point. So I would prefer PARP first and followed by immunotherapy because of the Olympiad trial data, which said that if you have less 0 lines of therapy, or if you use it first line, you get the best hazard ratio.
So you have in the
Nilesh, this patient progressed within 6 months of completion of treatment.
Correct.
And Impassion study 130 had included patients who relapsed after 1 year. Correct. So medico-legally, we should not be offering immune therapy to this patient. Because
what about pembrolizumab?
The data is there, but FDA approval is not there. The data
FDA approval in India. You mean?
Yeah, the data of PFS is there. That is keynote 355, if I'm not mistaken.
Yes, it is 355.
There they had taken less than a year also, where there was gem, carbo plus pembrolizumab was given, and they found a PFS benefit. But the OS data is not there, FDA approval is not there, recommendation is not there. What my point was that this patient has an early relapse and is not a candidate for atezolizumab plus nab-paclitaxel based on the inclusion criteria of Impassion 130. That was my
point. Fair enough. So we had discussed, it was discussed by Dr. Sudeep also that in the previous talks also that in patients who had not received chemotherapy, there was an improvement, a significant improvement in the overall survival, as opposed to patients who had received multiple lines of therapy. And the conclusion of the trialists was that you should probably use PARP inhibitors earlier on in patients who have a germline mutation. So essentially, to just summarize, the Olympiad had patients who had taken up to 2 lines of therapy. They had platinum-sensitive disease, that is without, they had not received platinum for at least a year. Half of the patients...
You'll have to go to the last slide, please. The time is up.
Okay, fine. So this is a keynote 355 that Amish was mentioning. We have an improvement in those patients who have a CPS score of more than 1 and in those patients who have more than 10. I would have wanted to discuss about the sequencing, but I'll come to the conclusion. So routine platinum use in TNBC is no as per the recent St. Gallen's guideline, but I think as we discussed, it is justifiable in certain group of patients. We are not yet treating our patients based on biological subsets, for example, basal, non-basal, and the luminal AR types. Immunotherapy and anti-androgens in NACT is no, and it's only on trials. PARP inhibitors in NACT, I think we don't know the role, and we have much more effective compounds like platinum compounds in this setting. Capecitabine in residual disease, I think a thumping yes from all of us here. PARP inhibitors in metastatic disease, yes, for those patients who have BRCA positive disease and HRD positive metastatic disease. And immunotherapy, I think the data is still weak. We are still awaiting longer data. And I think with that, I'll end my slide. Thank you all for participating.
Thank you, everyone. I now request Dr. Vineet Talwar, medical oncologist from New Delhi, to please give the expert comment. Over to you, sir.
Thank you, Kashish. As usual, TNBC is a very, very interesting session, and sometimes you get into heated debates. The importance of pathological CR, they cannot be overemphasized, since it's both a prognostic and a predictive marker, and it is a surrogate marker for overall survival, as it has been discussed. And also the definition of pathological CR was clarified very nicely, which showed that absence of invasive CA in breast and axilla and no DCIS. Now, the other thing is coming to the newer drugs, if you have to increase the delta, platinums, they have caused improvement in the disease-free survival, as it has been discussed here. And in a small subset with the BRCA positive patients, they have benefited more. But routine usage is at this point of time in NACT not advocated. PARP in single agent, there is no role. Checkpoint inhibitors, as the keynote 522 study was there, that has led to a totally different landmark, where you have a PATH CR going from 35-40%, which is the standard, to 51, which is with the platinums, up to 64%. So you have almost a doubling of the pathological CR. And this is, most starkingly irrespective of the PD-L1 scoring. Whereas in the metastatic setting, you have PD-L1 scoring, which improves it. So if you have a residual disease post-NACT, CREATE-X trial is the one which is a landmark trial. And of course, we have debated about the doses. You have the GCAM and the CISAC study. The best results are, again, when you take the actual doses, which in the physical or, the clinical probability is not possible. And if you have an early relapse in these cases after the maintenance, vis-a-vis you have the late relapse, you have a progression, then of course, after 2 lines, if the patient is still platinum sensitive, the patient is BRCA positive, these patients tend to do better with the PARP inhibitor, and then the sequence can be PARP, then followed by immuno-oncological drug. So TNBC is again a very, very bourgeois gamut in which the lines, the borders are changing very, very frequently. You used to talk of 35 to 40% paths here. Now you are jumping to 64%, 65%. Unimaginable, but we have to hold our horses still. I think at this note, I'll hand it over to the organizers.